Hi there, this is your moderator, Lori Dearman, and you're in the right place for empowering you, the future of technology-enabled care, to transform population health management, featuring Roween Roshan and Tim Rowan. In just a minute, we'll be introducing our speakers, as today's webinar is about hearing from these experts as they discuss how technology-enabled care will change the face and the future of healthcare. But for now, let's get started as we do have a lot to cover. Now, we've invited you with over 350 professionals registered from 44 states and provinces representing a variety of industries. And before today's webinar, we asked each of you to tell us what you hope that you would get out of today's webinar, and many of you chose to weigh in. Thank you for your input. I think you'll find that our speakers have done their very best to cover those items today. Regardless of your role or your location, we're confident you'll find today's webinar of value. I'd like to go to our first interactive poll for today. And if you wouldn't mind weighing in, that poll's coming up on your screen right now. And on the honor system, we'd like you to select your top 2 options here. I want telehealth to achieve. Your choices are improve patient engagement, case management efficiencies, reduce hospital admissions, readmissions, remote monitoring of vital signs and symptoms, a competitive advantage to grow and expand your business. All right, let's take a look. We've got 42% citing improved patient engagement, 34% case management efficiencies, 60% reduce hospital admissions and readmissions, that's our front runner, 29% remote monitoring of vital signs and symptoms, and 36% a competitive advantage to grow and expand my business. So thank you very much for taking a moment to weigh in on that. I think the results are very interesting for our speakers as they go through their content for today. Our first panelist for today, we have Roween Roshan, and it's a pleasure to have you with us today. Roween, welcome to the webinar.
Thank you, Lori. Good to be here.
Now, before I pass the mic over to Roween, allow me a few words in the way of an introduction. Roween is an analyst in the medical technology team at IHS. He covers topics such as wearable technology, consumer medical devices, telehealth, and healthcare IT. Roween is a quoted analyst on Forbes, Fortune Magazine, Wall Street Journal, Washington Post, Al Jazeera, and other media outlets. Before joining IHS, Roween held positions in analyst and consulting roles. Roween received his Bachelor's of Science from Copenhagen Business School in Denmark, where he conducted research on NFC-based mobile payment systems. He received his MBA from California State University, Long Beach, in Long Beach, California. Roween is based in Los Angeles, California, just down the road from me. So at this point, over to you, Roween.
Thank you very much, Lori, for that great introduction. Again, my name is Roween Roshan. My job is to cover technology in the mHealth space. I've provided commentary on telehealth for a number of years. And beyond telehealth, as Lori mentioned, I cover wearable technologies and consumer medical devices. Again, my contact info is provided throughout the presentation, so if you have any questions, feel free to reach out after this webinar. So today, I will be covering the technologies that we at IHS believe will shape the future of telehealth. This is both in terms of devices, but also platforms and applications. Before doing that, I want to address some of the inherent definition problems that exist in this market and some other macro factors as well. So if we take a look, and your definition or perception may differ, and that's the thing, terms like telehealth, telemedicine, telecare, they're very much aligned with each other, and therefore they're being used interchangeably. But I want to clarify this before going into telehealth so that we are all on the same page. So telehealth is defined by remote patient monitoring, that is monitoring of vital signs after an episode of acute care or long-term chronic disease management. Telemedicine is what we often refer to as remote consultations. These may be high-end telemedicine services such as the ones offered by American Wall, or now even Walgreens with their collaboration with MD Live. But it is also used in specialty care such as in dermatology or mental health. Finally, we have telecare, and this refers to the use of personal emergency response systems. one final note before I go into some of the macro factors and then eventually the technologies is that historically and currently these three types of remote care technologies have been more or less separate markets. But we do see convergence quite a bit, especially between telehealth and telemedicine. And the main driver of that has been technology. Just to go over some trends before going into the technologies, so healthcare as we know it today is heavily focused on acute care, on the sick population. And that makes sense because those are the most costly ones. But what our healthcare sector and what most healthcare sectors around the world has failed so miserably at is educating the population on their own health. And that really has to go beyond PE at school or half-hearted attempts in raising awareness for preventive care. And honestly, what we know as preventive care today is more or less home diagnostics with no follow-up actionable advice. And not many people know about their how their bodies work in terms of nutrition, physical activity, and sleep. And unfortunately, once they find out, it's likely to be too late. Now, it's easy for me as an analyst, covering technologies to sit here and say these things from the outside. There's no doubt that it's not easy to manage population health. It's a major undertaking. I don't want to seem ignorant, but I do want to say that there is a mismatch between what outcomes we want in healthcare and the outcomes we've gotten in the past. And technology sort of is referred to as a savior in many areas in healthcare. For many generations, technology has promised as great things, and most of the time it's been on the back end in terms of EMR, IT systems. And telehealth is sort of the first ever technology in healthcare that successfully manages the continuum of care from the patient's point of view. It does that in an effective and efficient manner. It increases patient adherence and patient activation measure, which reflects the patient's ability to manage his or her own health. It educates the patient and puts them in control. And more importantly, and you guys, 40% of you sort of focused on engagement, patient engagement. Patient engagement is retained through telehealth over, a long period of time because there's that authority figure, that being the provider. Now, all of this sounds great with telehealth, but how come very few provide it? Telehealth has existed for more than 20 years. Historically, very low adoption and failed implementations have been the main headlines. It's one of those innovations that was ahead of its time, and that's really not meant in a good way. Now, costly equipment usually has been the main problem. In other words, provider lock-in impacted the market very negatively in its early days. However, that does not take away its potential and its uptake in recent years, and I'll explain later why this uptake has taken place. And in addition, there are many telehealth programs out there that are successful, especially the VA that we're all very familiar with. So let's take a look at how telehealth is actually delivered to the patient. In terms of technology, the way that telehealth is delivered, it happens through a hub, which is the gateway device that collects data from peripheral devices such as blood pressure monitors, weight scales, thermometers, and a lot more peripherals depending on what disease condition you're monitoring. And sort of the overall trend in terms of technology being the hub or the peripheral is that there's a lot of emphasis on making it as cost efficient as possible and as effective as possible. So to start with, I want to discuss the health hubs. It's a key factor in delivering telehealth. So the hub is very important. I mentioned earlier that the market has seen uptake in recent years in terms of adoption and growth, and this is all to a certain extent due to the hub device. The majority of vendors have gone from conventional devices that are proprietary and thus more costly for the provider to mobile health hubs. These are consumer-grade devices such as smartphones and tablets. Now, mobile health hubs are cheaper, they're more interactive, the patients are used to using them because they have similar devices at home. They're also more capable. I also mentioned that we see some convergence between telehealth and telemedicine, and this is technology driven because many of these devices, for the most part, have front-facing camera, and you can actually use that for telemedicine. So we're seeing that emergence of consumer-grade electronics, going into healthcare, and it's really amazing what it's doing in healthcare, both from the clinical side to the patient's home. Ultimately, because telehealth vendors use mobile devices such as smartphones and tablets, patients realize that they could be using their own devices for this, which is very true. And multiple telehealth vendors now offer BYOD solutions, that is, bring your own devices for the patients. And the ones that aren't, they're actually planning on doing so in the near future. I'm out there talking to many telehealth vendors, and all of them have BYOD in their plans. And what BYOD is doing for telehealth is making it even more efficient. And let's not forget that it's not all about efficiency either. Luckily, these mobile health hubs, they're preferred by patients, just like smartphones are preferred by consumers. And treating patients as consumers can, be very valuable in certain instances. On the peripheral side, sort of same overall direction as in the hubs, making it more efficient, but most importantly, more valuable. So 2015 is the year where multifunctional consumer medical devices will hit the shelves, and these can be used for telehealth. So basically, instead of having 3 different peripheral devices, one device will, conduct the measurement necessary to track multiple vitals. Examples of these devices are Scanadu Scout and SensoScan, and basically, again, more efficient, but also more frictionless. A patient doesn't have to deal with, 3 or 4 devices. All is done in one. We also see quite a bit of activity in the wearable segment. Now, when I say wearable technology in healthcare and medical, I go beyond fitness and wellness, and that's really important because it has to be somewhat valuable within a medical context. So we're talking about devices that can be worn for as little as 5 minutes per day to do one full measurement, or patches that can be worn for 3 to 7 days for continuous monitoring. Examples of these are IntelliSense, Sensium Vitals. You got the 2Sense device, Vital Connect, ePatch. Again, a lot of activity in this segment. So both the multifunctional consumer medical devices and wearable technology, again, very frictionless and unobtrusive. That's very important. And the value proposition, is significant when comparing to having 3 to 5 peripheral devices, both on the provider end, because essentially that's more cost efficient, but also from the patient experience, that being more convenient. So very much focused on making things efficient, cheaper, more valuable for the patient as a consumer and not just as a patient. Again, in conversations with telehealth vendors, they're looking to deploy technologies like these. This is just not talks. We're actually seeing this, being applied in the market space. So, the technologies that I've gone over so far, they represent the current or short term of telehealth. Again, mobile health hubs, wearable devices and patches. Let's take it a bit further than that. Ultimately, the most frictionless, intuitive, and efficient solution would be to use the mobile health hub, so the actual smartphone or tablet, for all aspects of telehealth. In other words, you would have sensors built in the handsets that would measure all the vital signs necessary and transmit them directly to the provider. The current application of such technology is somewhat nascent. We know that Samsung has a couple of devices with optical heart rate monitors. Obviously, we need to go beyond just heart rate for it to be valuable in telehealth. But this is, sort of the future. Again, as frictionless as the multifunctional devices or wearable technologies are, nothing would be more frictionless than actually having all the sensors built in one device. At one point, having it all in one would be more valuable. There are, however, some limitations. Obviously, you can measure weight on a smartphone or tablet. However, it's common in many homes to have weight scales, and that I do not consider that being a major barrier for this type of technology. And one final note, we talked about BYOD. Imagine this type of solution in a BYOD setting. I mean, there would be no hardware expenditure for the provider at all. It would only be the monitoring part of it. So again, a lot more efficient and more effective. So beyond hardware, and now we're going into somewhat the platform application space. Beyond hardware, a lot of things are changing as well. The need for patient data is more important than ever, as it is an essential element of the ACO business model, and therefore patient-generated data at home is a priority for a lot of the ecosystem players in healthcare to capture, both payers, providers, but also for patients themselves. They want to have more data on themselves and their relatives. And there are new platforms out there trying to solve this problem. So, telehealth as we know it today is somewhat a health service prescribed to patients. Now we're going from remote patient monitoring to people monitoring, and there are a few platforms out there. Tactio is one, where they are merging sort of medical data as well as fitness and wellness of the general population, and not necessarily only the sick population. And going beyond that acute and chronic care is important, both from a healthcare standpoint, but also from a societal point of view. That would inevitably make it preventive care if we actually focus on the entire population. Other platforms, and this is more on the back end, Validic, getting a lot of attention currently. They have the role of a data aggregator. So what they do is, they have access to medical devices out there, fitness and wellness devices and mobile applications. Their ecosystem has a size of potentially 100 million people, and they gather data from that entire ecosystem, make that available for providers, payers, and even pharma. So again, that's more on the people monitoring side. Its value proposition is more long-term though. With telehealth, it's very evidence-based that in the short term there are cost savings as a provider. This type of people monitoring, there's no doubt that the value of that is long-term in terms of population health management, but you can't compare this to telehealth. However, it's an important trend to make aware of, that there are platforms out there looking at populations beyond just the sick population. So what now? I mean, we've talked about telehealth and its sort of low adoption. When looking at innovations, the success of innovations depend on two measures, referring to co-innovation and co-adoption risk. And if any of you have read Rod Nanner's book, The Wide Lens, you're familiar with these terms. So co-innovation risk refers to what technologies must be co-innovated in order for telehealth to provide value for patients. Now, had this been 3 years ago, co-innovation risk would have been high. At that point, we had no mobile health hubs. There was not a lot of innovation on the peripheral side. And since telehealth, sort of is evolving, we see those barriers going away. The co-innovation risk is not high at all. Technologically, other factors such as connectivity and bandwidth, not a problem at all. Not in the Western world, not even in emerging economies. So co-innovation risk, very low. If you look at co-adoption risk, that's more in terms of who needs to adopt telehealth in order for it to provide value for your patients. And it's a lot more difficult in this area, compared to its potential. Again, low adoption of telehealth. And why is that? So payers play an important role in this aspect. Reimbursement, sort of a major factor. It is increasing for telehealth. In fact, as of January 1st, CMS is expanding reimbursement for remote patient monitoring of Medicare patients with 2 or more chronic diseases. And we've seen this trend, over many years that reimbursement have been increasing. It's still low considering the overall cost of telehealth, and that's a barrier. As a provider, that's the main thing that you look at. And then two, the providers, they for obvious reasons play an important role here. I think it's important for providers to revisit the idea of implementing telehealth. Things have changed a lot. Telehealth is as much cheaper than 10 years ago, 5 years ago, and even 2 years ago. And the value proposition really fits the overall direction healthcare is going. And I don't doubt that it will be an essential part of patient care. And sort of the evolution in telehealth that we're seeing is technology driven, and it diminishes the gap between clinical care and home health, and that is where the efficiencies and the effectiveness really kicks in, and patient engagement. As you can see in the chart here, it sort of shows our one of many figures from our report. This one shows our shipment estimates for mobile health hubs contra conventional health hubs. Again, mobile health hubs, a lot higher growth. This translates into the number of patients that are remotely monitored in the U.S. So in 2013, our report identified around 300,000 patients being remotely monitored in the U.S. through telehealth. In 2014, that number increased to 425, and in 2018, we expect it to reach 3.2 million patients. And this growth is supported by the radical advancements that are happening in technology that is making telehealth a lot more efficient and a lot more effective, and sort of really takes on the challenges that you have as a provider in the U.S., especially tackling the readmissions problem. Back to you, Lori.
All right, thank you so much, Rowan, and don't go too far. We'll have you back at the end of the program to help us answer the questions that are coming into the queue. And our next speaker today, we have Tim Rowan, and Tim, it's a pleasure to have you with us today. Welcome.
Thank you, Laurie. It's a pleasure to be here as well.
And before I pass the mic over to you, Tim, just a few words in the way of some background. Tim Rowan is the editor and publisher of a weekly newsletter, Home Care Technology Report. It's home care's most trusted source for technology news and analysis. Since 1998, he's kept an eye on the healthcare technology innovation and on the industry's technology vendors. In network design, installation, and training since 1986, Tim has served as the IT director for a Colorado home care agency for 5 years. When not writing, he continues to work as a consultant, guiding numerous home care agencies through the software selection process. The father of 4 grown children and the grandfather of 5, Tim holds a master's in education from Loyola University in Chicago and lives in Colorado Springs. Over to you, Tim.
Thank you very much, Laurie. Hello, everyone. It's a real pleasure to be here. I want to follow up on Roisin's excellent presentation by putting it into the context of what the situation home health agencies, private duty home care agencies find themselves in today as we are about 4 years into healthcare reform, with reform going full speed. And I think putting it into the context of the political and economic and demographics environment will help to make Rowan's statistics and predictions make a little bit of sense in the real world. So I see the plight, if you will, of the home health environment today as kind of a balance, almost between the good and the bad. And I marked this initial slide as a balance between 2 major elections, because there is always going to be a political component to the world in which both Medicare and Medicaid and even private duty skilled and non-skilled providers have to live. So if you think of it in terms of here's where we are right now and here's where we're going to be in about 5 years, the first point that I think is important to make is that all healthcare providers have to get into their mindset to accept the fact that healthcare reform is here to stay. And it doesn't matter if it's the Affordable Care Act or something different that the Republican Congress comes up with now, or if the White House changes parties in January 2017, none of that matters. It might take on a different form, but because the U.S. healthcare system is so expensive and is consistently rated by the World Health Organization and others as somewhere around the 37th best in the world, change absolutely has to come. We can't sustain it this way. So get in your head that healthcare reform in one way or another is staying. And if it stays in the current format, expect that the accountable care organizations are going to continue to form at the rate of about 120 per year as they have been. And this is a major factor in the way in which healthcare is going to be delivered and the way home care is going to be relating to acute care and community care. The other thing you have to keep in mind is the demographics. I know that this has become a cliche. It's almost a part of every presentation, but the important thing to point out is that by the time of the next presidential election, the 76 million baby boomers are still not going to be of an age that is common for home health care. So I think we still need to be thinking in terms of continuing to care for the World War II generation and the in-between generation between the greatest generation and the boomers for a number of years. And home care is also not going to be dealing with the influx of millions of people who are now eligible for expanded Medicaid in the states that have accepted that additional money, because these are not your typical home care patients either. But it's important to keep an eye on the leading edge of the boomers, because in 5 to 10 years they are going to be in the age group of the average typical home health patient. So it's good. This is a time of preparation for that, not a time to deal with it directly. You got to take a look at the changing payment systems as well. If these new shared savings and bundle payment systems come in, it's very likely that what will happen is that the ACOs and the hospitals are going to be given 100% of the dollars for an individual patient, and then they in turn will subcontract with community post-acute care providers such as home health and skilled nursing facilities and long-term care hospitals, hospice, and the rest. So home health needs to get in its mindset that the way in which it markets and the way in which it is paid is necessarily going to have to change. And then, of course, don't forget that hospitals are going to continue to be greatly concerned about readmissions and looking to the post-acute care community to help them with that problem. So because of the change, because of the turmoil, I have been seeing a lot of interest in home health to diversify and take on different payers. So I've seen a lot of Medicare home health agencies looking at moving into Medicaid or moving into a private duty side of their business. At the same time, I've talked to private duty providers that are getting interested in Medicare as a second payer source, and vice versa. There are some Medicaid-only agencies that are looking into private duty and Medicare. So everybody is in this mindset that the grass is greener on the other side, but it's a smart move to diversify from a single payer to multiple payers in order to protect yourself against changes that are coming in the future. And we have to talk about the competitive environment as well. If you just look at the Medicare providers, the rate of growth of the number of Medicare certified agencies is an unsustainable rate. It can't continue to go this direction, even with the baby boomers coming into the home care arena in the next 5 to 10 years. And CMS doesn't want it to continue to grow in this way either. And so they have taken some steps. They would be very happy to write 6,000 checks a month instead of 12. But this isn't all the information. It's important to look even closer at what's going on here with the growth in Medicare home health providers. And I believe you can equate it to the non-skilled, the private duty, and the private insurance providers as well. I think the numbers parallel each other, although there's no one out there counting them like there is in Medicare. So take a look at the number of agencies that are grossing $2 million a year or less. It's more than half of the total number. And in 2013, the year with the latest numbers we have available, more than almost 2/3 are what you would call small agencies grossing $2 million a year or less. But look even closer again, and nearly half of them are grossing $1 million a year or less. This is a situation that is clearly going to change. This is not sustainable. As CMS is trying to reduce the number of Medicare certified agencies so that it can reach its goal, whatever it might be. It's an unstated goal, but I believe firmly they're very interested in writing 6,000 checks a month instead of 12. The ones that are going to be hurt by the measures CMS is taking are these little tiny mom and pops, grossing $1 million a year, employing 4, 5, 6 people, managing 50 patients a year at best. And these are people that are never going to be implementing telehealth systems. They barely have any computer system at all. A lot of them use Haven, the free software from CMS, just to get an electronic bill out the door. So in CMS's opinion, 12,611 as of last year. I don't know what the number will be. We'll find out in a month for 2014. There is way too many. Just to give you an example, there are pockets of places where this number is artificially boosted, like Houston, where there are 800 home care agencies just in the city limits of Houston. So I think that the Medicare Payment Advisory Commission and CMS have gotten together to come up with a solution, and this is only halfway meant tongue-in-cheek. And the solution is to reduce the payment rate. And if you're in the private duty business, don't think that you are exempt from this, because the private insurance companies are doing the same thing. So reduced payment rates are going to make it very difficult for the mom and pops to survive. The increased paperwork load is going to make it more difficult. The only way they can meet that is to hire more people, and they can't afford to do that. And at the same time, they are commissioning their audit contractors of all different kinds, and there are at least 4, if not more, of those contractors out there scrutinizing your clinical documentation, looking for excuses to deny payments, looking for excuses to recoup payments that have already been made. Under the stated goal to eliminate fraud, they are not distinguishing between criminal element and agencies with clinicians that have sloppy documentation habits. Whether you make a mistake or you're intentionally trying to defraud the government, they don't care. They're just going to go after you and take money back. And so who is this going to hurt? It's not going to hurt the agencies with a 20 or 30% profit margin. It's going to hurt the little guys with the 2 or 3% profit margin, or the occasionally negative profit margin. And this is the way that they are going to reduce the total number and perhaps achieve this goal of reducing the number of total home care agencies. These are numbers that, of course, I made up, but I don't think that they are too far from what we will actually see happening. And I don't base this just on numbers that I have come up with out of my head. I've talked to a number of experts around the country, consultants of all types, from attorneys to Medicare appeals consultants, Medicare payment denial appeals consultants, to people that watch the statistics year in and year out. And they all seem to tend to agree somewhere between 6,000 and 8,000 is the number that CMS would like to see over the next few years. So as we continue to explore the environment in which home care is trying to survive and thrive today, you have to pay particular attention to the partnerships with hospitals and the dilemma that hospitals find themselves in. I think that in order to control their avoidable readmissions, hospitals are of course going to look to the post-acute care community for help. But what you have to consider is that the hospital's dilemma is much larger than you might originally have thought. This somewhat complicated formula is meant to explain that a typical hospital, a hypothetical hospital, let's say they bring in $100 million a year from Medicare, and let's say they're at the maximum penalty rate for this year, which is 3%. Their hit is not $3 million, because at the same time, if they don't reduce their readmission rate, they also have to take care of these patients without further reimbursement for the care that they are giving for the second admission. So let's say if they do have a 23% readmission rate, that means out of the 2,000, on average, 312 patients discharged, 533 of them are going to be coming back. If it costs them $1,100 a day to take care of these patients, you're adding another $3 million onto the hit. And if some of them come through the ER, there's an additional expense there, which means these hospitals are looking at a $6+ million hit, not just $3 million for the penalty for every patient that comes back. So they obviously are looking for help. And here's my fear, is I see a lot of hospitals today that are thinking that they can do it themselves. I see hospitals, ACOs, and physician clinics with in-home care post-discharge follow-up programs. Why is this? They tell me because they couldn't find any home care agencies in their region that had the technology, that had the remote patient monitoring, and that had the low readmission rate of their own that they could trust to give their patients to. This is probably the worst news that home care is facing today, is that the hospitals are going to try to do it themselves and not turn to the post-acute community, not turn to home care. So in my opinion, this changes the way in which home care needs to market itself. It no longer makes any sense to send salespeople out to a doctor's office and beg for an additional referral or two from time to time. The only thing that makes sense is for the home care salespeople to grab their CEO and make an appointment and sit down with the hospital and ACO executives and say, here we are your savior, you need us, this is what we can do for you. But they're not going to do that with all of you. I talked to Cedars-Sinai Hospital, for example, in Los Angeles. They sent out bids to hundreds of home care agencies in Los Angeles, and they selected 5 partners. There's a new ACO here in Colorado that opened up a year ago and selected 4 home care partners out of 100 that were available and wanting to partner with them. So if you want to survive and thrive through the healthcare reform era, what kind of agency is going to be selected as a partner with hospitals and ACOs? I think you first have to demonstrate that you have already an excellent track record at keeping your own readmission rate low. I think that you have to be focusing on readmission with a variety of different kind of programs, and I think that these hospitals and ACOs are going to be partnering only with the most technologically sophisticated post-acute partners out there. The number one technology that they are all looking for is interoperability. Your software vendor has to be helping you to exchange patient data with the hospitals and ACOs. If not, they will not even look at the other technologies you have. They'll write you off right away. And then the second most important technology is your ability to look in on every patient every day without having to bear the expense of sending your clinicians out to the home every day. That means home telehealth. That means remote patient monitoring of all of the types that Roween mentioned to you, whether it be the agnostic devices where software where they can use their own tablets and cell phones, whether it be the hubs that are traditionally put in the home, like the ones Bosch provides, whatever it might be, the ability to know every day how the patient is doing, even if it's just a telephone call, is going to impress these hospitals and ACOs. And then you have to include the rest of the technologies. Personal emergency response systems, both fixed and mobile. Electronic medication management systems, because medication mismanagement is the leading cause of unavoidable hospital readmissions. And as an aside, you also need to know if your patients are actually filling those prescriptions. Most of the reason for medication mismanagement is financial. And so send your social worker in there to know for sure that they've actually filled the prescription, and look for help within the community if they can't. And then the other things that you've already been doing for a long time, fall prevention and focusing on CHF and diabetes patients, and educating your patient about their condition with the goal of making them self-sufficient, getting them engaged in their own care plan, which is a goal that telehealth can help with as well. If you've got a clinician talking to the patient every day electronically to remind them about their care plan and their responsibility to make sure that they are participating in it along with their families. There's a whole new arena of patient portals that a lot of companies are coming out with today that are helping a great deal toward keeping patients engaged in their own care plan. These are the people that hospitals and ACOs are going to partner with, and they don't have to apologize for it. If they're selecting 5 out of 100 to partner with, they can pick the best. They can cherry pick the best, most technologically advanced home care agencies, and we have already been seeing that that's what they are doing. History is already showing that. So when you send your sales staff and your CEO to sit down with the ACO and hospital executives and say, this is what we can do for you, I think this is one of the first things you tell them. You as an ACO know that you have these 33 quality metrics to meet in order to get your bonuses from this pot of federal money that's being accumulated through shared savings. You have to prove that you are providing better care, better patient outcomes, that the population health generally is improving among all of the patients assigned to you, not just the ones that you see every day, and you have to prove that you're doing it at a lower cost rate. Well, all the studies that I have seen have shown that the benefits of home telehealth exactly match those outcomes, those goals. Telehealth can provide better care, better patient experience, improving quality outcomes at a lower cost. So you go in and tell the ACO executives, we have this excellent home telehealth program, and it exactly matches what you need to accomplish in order to get your bonuses. The reason this is important is because when the day comes that you are being paid as a contractor by the ACO, you can start to negotiate contracts independent of the way in which Medicare and private insurance pays. You can negotiate contracts that allow you to share in the savings that you generate for the ACO and the hospital. And I'm seeing more and more and more ACOs, hospitals, and private insurance payers interested in those kinds of negotiations, those kinds of arrangements where you keep track of how much money you've saved them and they let you share in a portion of it. So you've got the environment in which home telehealth, or in which home care is living today. You've got the challenge to survival that's being posed by Medicare, Medicaid, and private insurance. And you've got the path that you need to take to become a more technologically sophisticated organization in order to be one of the survivors. So what this all comes down to is, are we looking at signs of hope or despair for the future of home health? You would be discouraged if you looked at the rate at which home health has adopted home telehealth. Less than a third, barely more than a quarter after 20 years of these technologies being available. But once again, you have to look at these statistics more closely. And that comes from the most recent Fozzie Associates State of the Industry report. And this is where I'm going to wrap up today to leave you with a little bit of signs of hope based on the demographics that I've given you before. Even though barely over a quarter of all home health agencies are offering home telehealth systems to the hospitals and ACOs and to their patients, it's the medium to large size agencies that you have to look at, because they really have adopted it almost universally. As recently as 2013, 85% or more of the large agencies are offering telehealth. That means that the little ones, the ones I think are not going to survive, are not using it, never will use it. But it turns out that's okay, because the ones who are going to survive through healthcare reform are already offering home telehealth. So 5 years from now, what you're going to see is half as many home care agencies, all of them much larger on average because the little ones are going away, and most of them offering remote patient monitoring systems to the acute care community and to their private duty patients. So I think that there is reason to hope. It's just that if you happen to be one of these little tiny agencies that has no interest in becoming technologically sophisticated, it's probably time to start looking for a suitor. And from what I have been told by the people that manage mergers and acquisitions, they have never been busier, because all of these old tiny agencies have seen the handwriting on the wall, and they know they need to either be acquired or close their doors. So I'm offering you signs of hope. I think a little bit more than signs of despair, but this is a peek into what's obviously going to be coming over the next, I'd say even sooner, 3 to 5 years. So thanks very much for listening. Back to you, Lori.
All right, thanks so much, Tim. And folks, I wanted to cover off on just a couple of items before we get to the fantastic questions that are coming through the queue. So if you would like to continue the conversation with us on this topic or learn more, we invite you to download the IHS Telehealth Report 2014. The next edition will be published July 2015, which will include telehealth and telemedicine and innovative business models to access healthcare. Also, we have rowanresources.com, where you can find out about an array of services to the home care and hospice industry. You can also register for a free subscription to the Home Care Technology Report. And additionally, we invite you to the Home Care in Transition event that will be held April 13th through 15th in Scottsdale, Arizona. And this is for home care owners and administrators who want to learn how to survive in healthcare reform. And then lastly, of course, if you would like to reach out to Bosch in any way, they'd love to help you. At this point, I'm going to ask our speakers back to the virtual podium. We'll start addressing the questions. So our first question for today, going over to you, Tim. The question is, what is the status of reimbursement for telehealth?
Oh yes, the question that I am always asked. This is, there's actually 3 answers. If you're talking about Medicare, the status is that they are inching closer to realizing that it is cost effective to reimburse home health for remote patient monitoring. The most recent law that changes was only for physicians, but I think that you have to see that as a step in the right direction. So maybe before the vast majority of us retire, Medicare will start to reimburse you for remote patient monitoring systems. If you ask them today, they will tell you we already do. The amount of money that we provide you per patient under the PPS system is intended to provide you enough money to acquire these systems. And if you remember, going back to 2000, when PPS first started, the rates were very high because they didn't know what the right rates were. More and more data comes in, they know what the right reimbursement rates are, and they've been coming down, and they're going to continue to come down. So the wise agency owners are the ones that took the additional money in the early days of PPS and invested in technology then. In Medicaid, the second answer is that I think we're up to about 17 states that have begun to reimburse for virtual visits. So if you're using video and you're seeing the patient instead of driving out to their house through the video system, they're paying $2, $3, $4 per visit for that type of service. And then on the private duty side, you know, the thing to do is to go to the adult children of these patients and say, hey, would you like to take better care of mom? And here's what it's going to cost. And most of the time they say, absolutely, let's do it.
All right. Well, thank you so much, Tim. And
Lori, I skipped one thing, and that's private insurance. More and more and more private insurance organizations are contracting with post-acute care to share the savings and provide payments for telehealth too. Sorry to interrupt, but I just wanted to make sure I got that in.
that's perfect. Thank you. Let's go over then to Roween. And Roween, question we have here for you. What impact will business models have on the future of healthcare, specifically healthcare technology?
All right, so that's an interesting question. We got to sort of take a step back and see what is the role of patient data overall in healthcare. So if we take the population health business model, it's a very much data sort of focused business model. Basically what we're trying to do is identify different populations within our patient population, the ones that are very sick, the ones that are healthy, the ones that are in the risk group, and sort of get as much data on these patients as possible. So one source of that data coming from your sort of annual visits or your generally when you go to the hospital, whatever, any kind of interaction that you have with the healthcare sector. But the amount of data coming from that is somewhat limited, right? Because it can only be that many times during 1 year. If we take a look at the importance of patient-generated data, that's something completely different, and that is driven by healthcare technology. I mentioned some of the platforms that are trying to gather data on populations. As a provider, in order for you to provide population health effectively, you need a lot of data on your patients, and telehealth can definitely help with that. Telehealth is data-driven, whether it's continuous monitoring or maybe once a day. That's a lot more data points for you to perform that predictive analytics that you need to do on your patient population.
Okay, thank you, Roween. And going to go over to you, Tim. The question we have here is, what are the key things home care agencies are doing today to thrive?
I think that that you have to look at maybe three things. One is developing partnerships with the acute care community. The other, of course, is building technologies that are going to create efficiencies and improve patient care. But another one that we haven't talked about that is becoming critical is getting involved with the process of patient transitions and care coordination. There are a lot of independents springing up today that are offering these kinds of services where they will manage patient care from one location to another as the patient is discharged from the hospital and perhaps moves to long-term care or to a rehab hospital and then eventually to home. I don't see any reason why home care cannot be the ones who make themselves the hub of those activities. Home care has the skilled nurses, it has the care coordination expertise. The nurses are accustomed to telephoning doctors' offices all day long to coordinate care, and it makes you more important to be the one in the community that is known as having the skill set, the expertise to take on a patient. It doesn't have to be an admitted home care patient, and guiding the process of meeting that patient in the hospital before discharge, keeping an eye on them as they move from one care location to another, making sure that they're moving at the time that's safest and for them and in their best interest. So I think if home care doesn't do that, other people will, and this would be a good time to offer that service within the acute and post-acute community. So those are the things I think I see people doing.
Perfect, thank you. Let's go ahead then to our last question for today. This is for you, Tim. We'll want to keep this on the briefer end as we're getting close to the top of the hour. Where do you think the private duty sector is going as a result of this reduction in home health sector? How does it fit into the ACO model?
The Medicare sector is restricted by the homebound requirement, and that's because Medicare has not acknowledged, and it's been closing in on 20 years now, that the number of Americans with acute diseases is far fewer today than the number of Americans with chronic conditions. The Medicare benefit, home health benefit, is based on a population that has diseases that they're either going to recuperate from or die from. But that's the minority today. People are not experiencing that today. The vast majority of Americans have congestive heart failure and diabetes and COPD, or combination of those things, and 3 or 4 or 5 different chronic conditions. And so the Medicare home care providers are virtually unable to care for them. So what you have to do is convince Medicare to get rid of the homebound and intermittent policy and let home health agencies provide for these people with chronic conditions over a long period of time. That's not likely to happen, and so this is where private duty can step in and charge a reasonable amount. It doesn't have to be a nurse all the time. It can be a lower paid home health aide or simply a companion type service to keep an eye on people who are suffering with chronic conditions. They're not going to get healed from these conditions, but they can learn to manage them. And so you form a team with the private duty provider, the family, maybe neighbors, and the patient themselves engaged on the team to keep them as healthy as possible as these chronic conditions gradually get worse and take over their lives. So private duty has a tremendous advantage because Medicare won't do it. And this is where they need to step in and offer their unique set of services at their unique price point.
Okay, well, thank you so much, Tim. And folks, we are at that time and would like to take a moment to thank each of you for joining us today. Hope you found today's webinar of value and you'll want to join us for some future events. And special thanks to our guests today, Rowan and Tim, and our sponsor for today, Bosch Healthcare. And again, as your moderator, this is Lori Dearman saying thank you and have a great rest of the week. Bye for now.